Hello, this is Dr. Sam Goldhaber. I'm president of NATF, and I'm speaking today on the Clot Chronicles on the topic of preventing pulmonary embolism and DVT in patients undergoing either total knee replacement or total hip replacement. It turns out that the number one complication after total knee or hip replacement has nothing to do with the orthopedic device that's inserted into the knee or hip. The number one complication is pulmonary embolism and DVT. And how should we best prevent this? Well, the guidelines are not very useful because they say you can do almost anything. Low-dose aspirin, low molecular weight heparin, warfarin, or novel oral anticoagulants are all considered to be acceptable approaches to prevention of venous thromboembolism after knee or hip surgery, specifically total knee replacement or total hip replacement. Recently, in the New England Journal of Medicine, a study was published where patients all received up front 5 days of the NOAC rivaroxaban. They received 10 milligrams daily for 5 days, and then they were randomized either to continue rivaroxaban for 2 to 4 weeks, and the other group that did not receive rivaroxaban received low-dose aspirin. And at the end of the study, the event rates for pulmonary embolism and DVT were thankfully very, very low in both groups, and there was no significant difference using the hybrid approach of rivaroxaban, switching to low-dose aspirin after 5 days versus continuing just rivaroxaban alone for 2 to 4 weeks. So this gives us another potential approach in our query and wish to stop DVT and pulmonary embolism after total knee replacement and total hip replacement. I personally, along with Catherine Mickelson at NATF and others, we are involved with a study called the PEPPER trial. This study will enroll 25,000 patients across the USA undergoing total hip or knee replacement, and they are being randomized to one of 3 groups: low-dose aspirin, or rivaroxaban 10 milligrams a day, or warfarin with a target INR between 1.7 and 2.0. And the idea is to see which of these 3 regimens will have the lowest risk of venous thromboembolism. We should have the results in about 5 years, but in the meantime, there are multiple approaches that are considered acceptable. I think the main thing is to be certain that some approach is being used with some type of pharmacological agent such as aspirin or oral anticoagulants or injected anticoagulants. Use some approach to prevent DVT in this vulnerable population. This is Dr. Sam Goldhaber signing off.